All right. So it's our last presentation, holy cow. It's been really great here. Our last presenter, Dr. Jack Westfall, is a family physician, rural family physician, and Chief Medical Officer for the Colorado Health Hub. His presentation is entitled Cold Spotting, Linking Primary Care and Public Health to Create a Solution. All right, thank you.
Tonight I'd like to tell you a story about an individual and a neighborhood, and an idea to consider as we try to collaboratively build a healthy community. I'd like you to meet Bill. Bill grew up in the San Luis Valley. He moved to Denver after high school. He has been a truck driver and a carpenter, now a cabby. He's disabled, unable to work. He's about 60 years old. Bill is a hotspot. He's had 7 hospitalizations this year for heart attack and heart failure. Pneumonia landed him in the hospital for a week. He has diabetes. And he's had 9 emergency room visits for chest pain, shortness of breath, cough, and leg swelling. Bill was identified by the local ER as a superutilizer, a hotspot. He was enrolled in a healthcare follow-up program funded by the city and a local foundation. Bill got better. He lost 30 pounds. He sees his family doctor every month or 2. He checks his blood sugar. He saw a counselor in his primary care office, and his depression is improving. He takes his medicine. He got better. Jeffrey Brenner, Dr. Hotspot, worked in Camden and identified this group of superutilizers as hotspots. He provided enhanced primary care and social services, and there was evidence that their health improved and their costs were lowered. This type of hotspotting identifies individual patients and improves the care of individual patients. But Bill's not that uncommon. In Camden or Philly, Fresno or Denver, there are a number of hotspots that have a lot of medical problems. Superutilizers. They cost the healthcare system millions. 5% cost 50% of our healthcare costs. Here's Jane. She's a hotspot. Hotspotting labels these superutilizers, puts a price tag on them, and reminds all of us that there are people who cost us more money. Bill got better. He moved out of his apartment, and Jane moved in. She has depression and diabetes and a part-time job. This is a map of the downtown area of Denver where Bill and Jane live. The red dots are the healthcare offices and the grocery stores. There's a poorly maintained park. This part of town has been called blighted. From the periphery of Denver's urban core, the 10-block Welcome Street corridor once thrived as a vibrant and high-profile urban tapestry of jazz and entertainment in the greater 5 Points area. Now a third of it is blighted, developed primarily as surface parking. The official definition of blight goes something like this: a preponderance of buildings dilapidated and deteriorated by age and inadequate light and sanitation, due to overcrowding, or any combination of these factors, and is conducive to ill health, transmission of disease, infant mortality, and juvenile delinquency. The Urban Dictionary puts it into common language and brings into context the social determinants of health. Blight, the feeling when walking through this part of town that the neighborhood has seen better days, is disintegrated and has above all crushing, inescapable poverty. But urban blight is not the only place where healthcare is disintegrated. There are suburbs and gated communities where people live in isolation, lacking integrated primary care and behavioral health, poor collaboration between public health and medical providers, schools, and community organizations. But are superutilizers the real problem? In Washington, D.C., 2 subway stops mean the difference in life expectancy of 7 years, from 84 to 77. In New Orleans, a difference of 2 miles means a 25-year difference in life expectancy. Certainly, not everyone in the region with a life expectancy of 55 is a superutilizer. They're not all hotspots. A community of solution is a 50-year-old term that may provide part of the answer. Rather than just pick out the individual hotspots, a community of solution finds the cold spots, places, neighborhoods, and communities where the healthcare problems are not just in individuals. A community of solution identifies the problem shed, that cold spot. And a community of solution identifies the asset shed, those who can provide a local solution. There's a growing community of solution in Bill and Jane's neighborhood. Seen here, people and organizations coming together with a local solution. There are individuals, organizations, and communities working to build a local community of solution to cure that cold spot. Improved housing, elimination of food deserts, building parks and walking trails. The problem sheds are being defined with locally relevant, actionable data. The asset sheds are built through collaborative relationships, tearing down silos, checking egos at the door, engaging the community in true, equitable, and equal partnerships. Cold spotting requires a shift in our thinking. Our problems are not just individual patients, but broader, systemic, community-based. The cure requires a community of solution linking public health, primary care, and behavioral health services in explicit partnerships. Together, when we build a community of solution, we eliminate cold spots, which also helps cure those hot spots. Thank you.